Thank you, Stephen, for the introduction, and thank you for having me here. These are my financial interests. And I will be speaking about perfusion MR body applications. So body is much bigger than the brain, and I will not cover the entire spectrum, and I will focus on tissue characterization and tumor characterization, and I will mostly speak about DCE MRI. So there are two questions when thinking about this talk. The first question is, where is Tübingen? It's in the south of Germany, a very small medieval town. And the second question is, why would we measure perfusion with imaging methods? So why would a clinician want to do this? And the thing is that we want to get more out of our images than just morphology. And what we are looking for is a biomarker. We want to find a parameter to characterize tissue. And the quality of a biomarker in clinical trials should be that the imaging biomarker is closely coupled or linked to the presence of the disease, and it should be accurate, reproducible, and feasible. And changes in this biomarker should also correlate with the change of when undergoing a therapy. And changes of the biomarker should be related to the medical endpoint. And we can do diffusion, perfusion, and all of these fancy techniques, but the only accepted imaging biomarker in clinical trials up to date in RECIST is just the size of tumors, and indirectly also the number of tumors. If there's increasing tumor, if there are new tumor metastases, then it's also progressive disease. But I think we can get more out of our images than just simple size. So, is size a good marker for tissue function? Of course, a smaller kidney is going to have a worse function, but it's difficult to assess quantitatively. What about tissue dignity? Is a big lesion more aggressive than a small lesion? We don't know. And what about cancer outcome? So the number of lesions, is this really correlated with the outcome? And can we say what is happening in the lesions? And is there a difference between a couple of histologic tumors, subtypes? So, and this is an example that size is not enough to assess tissue and tumor dignity and proliferation, because this is a RCC metastasis before and after treatment with an anti-angiogenic drug. And what we can see here is that there's clearly something happening in the tumor. We see less enhancement, but if we just measure the size, it's completely the same. And we would say that this would be stable disease, but we can clearly see that there's response towards the administered drug. The question is, are there alternatives to size? And this is work from a co-worker, Professor Sommer from Munich. And they have assessed if the tumor load, the hypervascularization, or the morphology of tumors can distinguish people or can predict long progression-free survival. And we can see that first, the proliferation index can distinguish between long survival and short survival, and we can see that vascularization of the metastasis of the tumors are also a good parameter to distinguish between people who are going to have a long survival versus a short survival. And the thing is that we can deduct from our imaging features, we can deduct characteristics of a tumor, and what we in the end want to deduce is the gene expression. So we can see that there seems to be a link between the vascularization and the proliferation index. So let's start. The question is, why is it important to measure tissue function? Why would it be important to measure renal function? And if you think of renal disease, chronic kidney disease, we can see that the percentage of people suffering from chronic renal disease is increasing, and chronic renal disease itself is also a risk factor for cardiovascular disease. And we can see that the costs for end-stage renal disease is increasing over the years. And if you think of biomarkers for end-stage renal disease, we have glomerular filtration measured with blood tests, which are not very sensitive. and we have invasive biopsy, which comes with all the complications, and we have nuclear medicine tests. So it would be good to have a non-invasive imaging test to measure glomerular filtration and also perfusion of the kidney. Same goes for liver. Why would we want to measure liver function? Mortality is rising for liver-associated diseases. And if you think of liver, so liver is a central organ and is not does not only give rise to primary tumors or metastasis, it's also central in the metabolic syndrome. And when we have steatosis, we might also get an inflammatory component, steatohepatitis, fibrosis, and cirrhosis. And we want to have an imaging method to non-invasively distinguish and quantify the inflammatory and fibrotic component of liver disease, and so that we can predict the occurrence of complications related to hepatic disease. So dynamic contrast enhanced MR is a good method to measure tissue function, and DCE gives us a fourth dimension to the three-dimensional morphologic information we have. So if we administer an exogenous tracer, we're going to get uptake in the organ, and this is already some kind of indirect test for tissue function. And now where we can measure really fast, we can assess also the arterial phase, we can see the microcirculation, the perfusion of the organ, and if we measure longer, we can see transfer of the contrast agent from one compartment in another compartment, and so we can see the excretion or the uptake of a tracer in an organ. And this is what it looks like in clinic. So we're principally following a bolus of gadolinium through its way through our organ of interest. I think we have seen this before. We can get the signal curves, so the first pass recirculation and then the filtration. Even applying, we have seen this before, pharmacokinetic models. We can calculate the blood flow and the blood volume if we know how much contrast agent is in the aorta. If we add another compartment, we can measure the transit from the blood compartment into the tubular compartment, which is basically the glomerular filtration rate, which is our biomarker for renal function. And we can do this in a topographic style, and we can measure the single-site renal function. For example, here in high-grade renal arterial stenosis, we can see that the perfusion is much less on the right side affected by the renal arterial stenosis, and this is a case in a patient with parenchymal disease, glomerulonephritis, and here we see reduced perfusion in both kidneys, which indicates this damage of the renal parenchyma. So one of the most important tasks for imaging tests to assess renal function is to assess the single-site kidney function, and this is important before renal transplantation, and we want to know which kidney, the right or the left, is going to be the one with the predominant renal function. And this is early work from Vivian Lee from NYU, where we can see a quite nice correlation between the nuclear medicine test and the MRI DCE MRI test in determining the predominant side of kidney function. And these are two more recent studies who have correlated the estimated GFR from the perfusion and filtration measurements, and here we can also see a quite good correlation and a not so big difference between these two methods, DCE, MRI, and scintigraphy. Here I want to show how you can use MR to get a more profound insight into pathophysiology, and this is data we presented at last year's RSNA, where we have investigated what is happening in kidneys after ischemia reperfusion due to a partial nephrectomy. And we can see that 1 week after ischemia reperfusion, there's a significant decrease of perfusion on the affected side. The contralateral side, interestingly, does not show hyperperfusion, and after 3 months, we can see that the perfusion is almost the same like in baseline, and here you can see before and after partial nephrectomy. In here we can see after 3 months that perfusion has come back, and we can also look at the glomerular filtration on each side, and we can see after 1 week about 50% reduction in glomerular filtration, and interestingly after 3 months glomerular filtration comes back. The contralateral side does not show very profound increase of GFR, only around 10%. And I think this is interesting data to understand, to see what is happening after ischemia reperfusion in the kidney and how kidney function returns just after 3 weeks. And there's also a correlation of the decrease of renal function correlated to the clamping time. This is also very nice work where Stephen was involved, and this is a study who has investigated which patients are going to benefit from dilation of the renal arterial stenosis. And there were 3 groups, and the one group who improved after dilation of the renal arterial stenosis was the one group with a reduced extraction fraction. So there seems to be a reserve, a functional reserve, which can be activated when using a dilation of renal arterial stenosis. So we can do prediction, and we can stratify which patients are going to benefit from treatment. Then thinking of a potential indication for perfusion MR in kidney, we should think about transplant kidneys, because here we quite often see acute rejections. Sometimes we also see acute tubular necrosis, while acute rejection has to be treated with immunosuppressants. And this is work from NYU, where they could distinguish between acute tubular necrosis and acute rejection by looking at the vascular transit time. And we can see that in acute rejection, the vascular transit time is much longer than acute tubular necrosis. And so we can do therapy decision based on perfusion MR. And this is experimental work we have done in mice. And here we can see that DCE MRI can also distinguish between different types or different types of allograft rejection. So this is complete full allograft rejection of the kidney. We don't see any or almost any perfusion in the transplant kidney. If we use a subtherapeutic dose of cyclosporin, we can see that the perfusion comes back. And if we combine cyclosporin with a chemokine antagonist, we can see that the perfusion is much better than only with the subtherapeutic cyclosporin. We even see hyperperfusion after ischemia reperfusion, similarly to syngenic transplant. So we can use DCMR to distinguish between different treatment types, and we could also see a correlation between perfusion and the degree of inflammation of the vessels in tumoral arteritis. So DCMR is able to provide non-invasive information about allograft rejection. So this is very interesting. However, functional MR and DCE MR is prone to errors. So one error is, are we going to measure just one single central slice, or are we going to assess the whole organ? And we do see differences when comparing results from single slice and whole organ tumors, particularly for plasma flow. We can see that the perfusion is higher when measured on a single slice, because we don't have the partial volume effects in whole organ or whole tumors. However, the fitting of your data will be significantly better if you use a whole kidney region of interest, because you have more voxels to include in your analysis. there's also a dependency of your data on temporal resolution. You need at least a temporal resolution of 4 seconds to do a 2-compartment analysis, and you would have to measure at least 4 minutes if you want to have a stable analysis. If you go shorter, then a 2-compartment analysis is not going to provide reliable data. So at least 4 seconds temporal resolution and 4 minutes acquisition. And then you're also dependent on the model you used. And this is work from NYU, very interesting, where they have compared like 1-compartment models versus 3-compartment models. And just depending on the model you use, you can get a difference about 50% on the calculated GFR. So we can clearly see that a white paper on perfusion MR with contrast agents is something we should also strive for. And there's also a dependency on the contrast agent you use. If there's protein binding, you will get a systematic underestimation of the glomerular filtration. So you should use only tracers which do not bind to albumin, because albumin is retained in the kidney, and thus you will underestimate your GFR. Another problem is that patients with kidney disease are patients who should not receive contrast agents, especially with end-stage renal disease. Alternatively, one might use arterial spin labeling, as we have seen before. And this is a patient with renal artery stenosis, where we can see the hypoperfusion on the right side. And we can also assess renal transplant, where we can see, in the case of deteriorated renal function, reduced perfusion, and we can see a significantly reduced perfusion in renal transplants who are not working completely fine compared to normal renal transplants. So coming from the kidney, we will go into the liver, and the liver has some interesting aspects. First, we have liver-specific contrast agents. So there are 2 contrast agents on the market. One is galvanic acid, gadolinium, which goes under the name of multi-hands. The other one is Primovist, Eovist, which is gadolinium EOB, very long name. I will just shorten it to EOB. And the one is a linear contrast agent, and the one is a circular contrast agent. And the main difference between those is that the hepatobiliary time is the hepatobiliary phase comes faster earlier when using gadolinium EOB compared to multi-hands gadolinium, where you would have to wait 1 hour until you see uptake of the contrast agent. And there's also a high biliary excretion of gadolinium EOB, and the uptake of the contrast agent into the hepatocytes can be detected using T1 weighted sequences. Gadolinium EOB, I will mostly speak about gadolinium EOB because this is more feasible for hepatobiliary imaging, because you won't have to wait so long, and it enters the hepatocyte on the apical side through active transporters, is not degraded in the hepatocyte, and then leaves via the bile canals and by the bile ducts. And this is how it looks like in clinical routine. And after 10 minutes, we can see a profound uptake of the contrast agent in the liver. And after 20 minutes, we can see the excretion here in bile ducts, while this non-hepatic mass, HCC, does not take up the contrast agent and stays dark. So there are some pitfalls using gadolinium EOB. The parenchymal enhancement can already be seen after 1.5 minutes. The arterial phase is not as hyperintense like in other contrast agents, and the uptake of gadolinium EOB is dependent not only on liver function but also on the thrombocytes, albumin, sodium levels, and you can see that in cases of hepatic or renal insufficiency, the uptake of this contrast agent is altered. For example, in end-stage renal disease, you will see that there's going to be lots of circulating gadolinium EOB in the blood, and the same goes for hepatic insufficiency. The worse the liver function, the less the hepatic uptake, the more the circulating gadolinium EOB in the serum. If you want to quantify gadolinium EOB kinetics in the liver, you would think of a more complicated, complex model, because in the liver you will have a dual inlet system, one in the hepatic artery, the other one in the portal vein, and you will have to enhance your one compartment to a two-compartment model, because the contrast agent is being taken up and stored in the hepatocytes. And this is how a typical liver enhancement curve looks like. We have typical first pass, and then we have the uptake of gadolinium EOB, and we can calculate the uptake rate, which is a quite stable rate in healthy patients. And this is how we can assess liver function. This is a patient who underwent radiofrequency ablation. We can see that here at the localization of the ablation, there's reduced perfusion. We can see a lower initial uptake of the contrast agent, but after 20 minutes, we can see that there is no defect in the hepatocyte-specific phase, and we can see that the uptake rate between ablated and non-ablated liver tissue is the same. So we can, using gadolinium EOB, we can calculate the perfusion of liver tissue, and we can also calculate the function of hepatocytes. This is also important work from Taiwan, where the parameters from perfusion MR with gadolinium EOB has been correlated with scintigraphic standards of reference, and we see a quite good correlation between the pharmacokinetic parameters and the scintigraphic methods, and we also see that there is a difference in the extracellular volume related compared to the grade of fibrosis. So we can non-invasively get information of the fibrosis degree of liver tissue. And this is important if you think of assessing liver function, for example, before tumor operation, if you want to know how the performance of the liver tissue is. And this is also very interesting. Here you can see typical curves of liver tissue. We can see the nice uptake. And if we have a non-hepatic mass, for example, HCC or metastasis, we can see the curve looks very different. We have a downslope compared to the upslope here, and we have also a nice fit of the one compartment model, which does not fit the liver data. And we can see that the uptake rate of this non-hepatic mass is 0. So this is very important information, and this might also help us in assessing borderline lesions, just like adenoma and high-grade HCC. So I think that there's quite an application for perfusion MR with gadolinium EOB. So this brings us from tissue function to tumor histology. And this is two cases of quite old patients, and those patients also have diabetes, hypertension, and they have a renal mass, which looks quite the same on morphologic imaging. If you look at the DCE sequences, we can see that the one mass is hypervascular, whereas the other mass is hypovascular. And if you look at the enhancement curves, we can see first pass on the right mass, a very high initial peak, whereas we see a slow upslope on the left side. And this one is clear cell renal carcinoma, the more aggressive histologic subtype, whereas the other one is papillary renal carcinoma, which is more benign. It's still malignant, but less aggressive. And so here you can really, you can assess the aggressiveness of a tumor using this non-invasive test. And this is also data which has shown that the perfusion of renal cell carcinoma also hints on the tumor histology, and the more aggressive, the more dedifferentiated a tumor is, the higher the perfusion is going to be. And DC MRI has shown to be the best discriminator between papillary and clear cell carcinoma. And so this information might help you to stratify an individual patient's risk, and if a patient has got a quite high perisurgical risk for complications, you might rather go on this patient for active surveillance, while this one you might still want to take out. So here we can see that DCMR helps us in determining individualized therapy. However, there's still difficulty in distinguishing renal cell carcinoma from benign entities like oncocytoma. This one here is also quite hypervascularized, whereas in diffusion we can see that the ADC is quite high. So perfusion imaging might not be ideal for distinguishing RCC from oncocytoma, but arterial spin labeling has been shown to nicely distinguish between oncocytoma and clear cell renal cell carcinoma. And with ASL, we can see that there's a significant higher perfusion for oncocytoma compared to all other types of clear cell carcinoma. So we can use arterial spin labeling perfusion potentially to differentiate those tumors. However, one has to say that the investigated groups were still quite small, with about 50 to 60 patients. So I've talked about kidney cancer. Kidney cancer is not that often. Much more relevant are the big players. The most common cancers, not the most deadly cancers, prostate cancer in women, in men, and breast cancer in women. And in these two tumors, perfusion MR is really already clinical reality, and perfusion MR is principally performed in every MR examination. So this is a case of a 64-year-old male patient with elevated PSA. We see here a suspicious hypointense mass in the left peripheral zone, which is also dark on the ADC maps. And here we can see how perfusion imaging helps us to further characterize this lesion. So this is so we can nicely see this strong first pass of this tumor, and also the washout. We can draw our region right here, and what we do see is a downslope after the initial strong first peak. And when doing pharmacokinetic analysis with the Tufts model, we can see that K-trans is also very high in this tumor, and this tumor so this patient underwent biopsy, and this was a Gleason 7B prostate carcinoma. And this shows us that DCE helps us to characterize prostate cancer, and it is integrated in clinical routine. And if you look at the PIRATES classification, the standardized classification system for assessing prostate cancer, we can see that DCE is integrated as a standard procedure, and we can give points for the profile, for the perfusion profile of tumors, and we can say if a tumor is most probably benign or most probably malignant. Same goes for dynamic breast MR, where we can distinguish between benign and malignant tumors, also based on the washout. This is fibroadenoma with a low washout. This is invasive ductal carcinoma with an intense washout. So the more aggressive the tumor, the stronger the washout. And this is how we assess perfusion MR, DCE MR in clinical routine. We don't do it, mostly we don't do it quantitatively, we do it qualitatively, and we look at the form of the curve. We look do we have a progressive curve, is there a persistent increase, so this is mostly benign. Decline after initial upslope is most probably malignant, and then plateau is intermediate, so we don't exactly know. And this is an example how temporal resolution is important to better assess the enhancement curves. Here we can see temporal resolution of 15 seconds. This almost looks like a plateau phase. With a temporal resolution of 5 seconds, we can better see this initial peak and can better address the downslope form of the curve. And it is quite difficult. Sometimes it's quite difficult to distinguish between a plateau and a washout or a persistent curve. And this is a nice study where quantification of the downslope or upslope was used on a computer basis. And we can see that when quantitatively assessing the late phase of dynamic contrast enhanced MR, we can greatly enhance our diagnostic accuracy compared to just qualitative analysis performed by 3 radiologists. And this is also a very elegant work from the same group where computer-aided analysis of the time curve was performed with the Tofts model. And one could see that the higher the permeability, the higher K-trans, and the lower the extravascular volume, the higher the probability that a mass is malignant. And you can and they did a pixel-based analysis, and they could see that although there's a plateau curve, there are a couple of 30% of voxel with a malignant curve, and this computer-aided analysis led to an also strong increase of diagnostic accuracy compared to a more qualitative approach. What about the diagnostic accuracy of DCE MRI compared to its competitor, ADC, diffusion-weighted imaging? And when we look at the area under the curve is almost the same for DCE MRI and DWI. And DCE MRI also increased a little bit the diagnostic accuracy combined with T2-weighted imaging. What is important to know is that when we combine T2, DWI, and DCE MRI, we will become very sensitive, however, at the cost of increasing false positive findings, because, for example, BPH, benign prostate hyperplasia nodules, also may show a washout behavior, and this may lead to confusion. So one is not sure if you should combine DWI and DCE MRI, but however, this is what we're doing for the PIRATES analysis. Regarding correlation to histology, so we're looking for a surrogate marker for tumor dignity. We can see that the more aggressive the tumor, the more increasing the Gleason score, the higher K-trans. And the same goes for ADC. The more dedifferentiated a tumor is, the lower the ADC. But the correlation of ADC to Gleason appears to be somewhat more precise than for DCE. And this is also data from the meta-analysis also showing that when combining perfusion and diffusion, we get a more sensitive analysis, however, at the cost of a reduced specificity with increased false positive findings. Alternatively, we also might use arterial spin labeling. So this is the first work that shows that prostate cancer also shows higher perfusion measured with ASL, and there's also a good correlation to K-trans. So there might be the possibility to perform a prostate cancer MR without exogenous contrast agents. But however, this is just preliminary work, and there's only one study out there. And another possibility to probably get a better correlation to the Gleason score might be two-compartment analysis, where we can just really get the true perfusion data separated from the permeability data, and but no study has systematically assessed this approach. Regarding response to chemotherapy, we can see that the type of the curve is changing after treatment. We can see that the downslope is not as profound after chemotherapy as pre-treatment, and so DCE MRI might also give us information on a response of prostate cancer towards chemotherapy. And this is a meta study which has analyzed many studies for prediction of neoadjuvant response in the case of breast cancer. And we can see that the one study who has used DCMRI with the Tufts model performed quite well with a diagnostic accuracy of 85%. But this was only one study, and we can see that DCMRI is good compared to just size or morphology. So I think this is very interesting data. This brings me to the last part of my talk, the assessment of tumor therapy. If we think of traditional therapy, we got destruction of tumor cells by cytostatics or radiation. We got a change in tumor diameter, which we assessed in RECIST. But when we use anti-angiogenic therapy, we have a disruption of vascularity. As we have seen, tumor size stays the same, but we do see significant changes in perfusion and permeability. And what is happening when using anti-angiogenic drugs? The thing is that we disrupt the function of VEGF, and so the pores of the vessels close, and we have less extravasation of blood and thus contrast agents. And those anti-angiogenic drugs attack the tyrosine kinase inhibitor of VEGF, of the vascular endothelial growth factor, so that we have less proliferation and less angiogenesis. And there are also new drugs which attack more downstream, the so-called mTOR inhibitors. So this is the example we have seen before, same size, but there's significantly less perfusion in the tumor. So, and there's a need for new criteria for response, because the standardized assessment using RECIST or CHOI is not enough to discriminate between responders and non-responders. And so this is truly an indication for DCMRI to be tested. And tumor perfusion is principally an old story which is being retold. We can see that there have been works in 1979 assessing tumor perfusion, and now with these new techniques we can get dynamic data with diagnostic quality. And I think this is might be a good way to integrate DCMRI in clinical routine. And this is a renal cell cancer metastasis, which we can nicely see. We can also see the tumor vessels in the muscle. And this is something a clinical radiologist will also accept for dynamic contrast enhanced imaging. So these are some cases. So this is a patient with neuroendocrine tumors after selective internal radiation therapy. We can see reduced perfusion after therapy, and we can also see that the first pass peak is lost, and we can nicely see that the liver tissue itself does not show significant alterations. And because of the alteration of the perfusion pattern, we would classify this as a responder. And this is another patient with metastasized renal cell carcinoma metastasis in the liver after 2 months. You can see that there's somewhat increase of the metastasis size, and we can see that the perfusion also increases in those metastases. And this gives us an additional parameter to assess the progression of this tumor. And we can see here this increase in perfusion, increase in tumor flow, and this patient can be classified as a non-responder. So another case, RCC metastasis in the left iliac bone. After 3 months, size is almost the same. And here we can nicely see that the perfusion is very much reduced after 3 months, and we can see the significant reduction of perfusion. And I think this case is clear. Size is almost the same, but the perfusion is dramatically reduced in this responder. And this is the corresponding ADC map, where we can also see an increase of ADC because of increasing necrosis in decreasing cell density. If we think of DC as a biomarker, we can see that there is significant correlation of blood flow versus mean vessel density. I just need 2 minutes. And there's also a significant correlation of DCE to necrosis. So we can use DCE to assess tumor histology. The thing is, this is something Michael English has also talked about. If we use the Tofts model, it might be difficult to distinguish between perfusion and permeability. And in a nice study performed in Leeds, one could see that there was a significant correlation between the perfusion measured with a 2-compartment model to the Tofts model, so that in cervix carcinoma, we are measuring perfusion when assessing K-trans, and we have similar data for K-trans and perfusion in renal cell carcinoma. At least in clear cell carcinoma, we can see that K-trans significantly correlates with plasma flow, but this goes not for papillary renal cell carcinoma because this is a more hypoperfused tumor. We can see changes in DC MRI as early as after 3 days, but many studies have shown that the decrease of perfusion did not correlate with the outcome, but the baseline perfusion did correlate with the outcome, and this is something DCE MRI might play a role in clinical trials, because there were 2 trials who have assessed the response towards an anti-angiogenic therapy, and they could see that a high baseline K-trans meant long progression-free survival, whereas a low K-trans in the baseline meant poor prognosis. And this makes sense because a hypervascular tumor is going to respond better towards anti-angiogenic drugs. And this is my last slide. This is data from HCC where we could see different data where the decrease after 2 weeks of K-trans better separated the overall survival and response than the baseline permeability. So we are not really sure how to interpret the data, and we need more structured and prospective randomized trials. So in conclusion, perfusion MR can be used to directly measure renal and hepatic function. It might serve as a surrogate imaging biomarker for characterizing tissue microcirculation. We can use it to assess tissue dignity in response towards anti-angiogenic drugs. And perfusion MR may predict response, either baseline or early response, but we first have to assess this in bigger studies, and we need standardization of quantitative perfusion MR, specifically DC MR, because it's difficult to compare results of different studies, and this is a method how to do it. So this is from our EU grant, where you would go from small animals toward big animals from cross-sections and longitudinal studies, and this is how one should assess DC MRI and integrate it into clinical routine as a reliable method. Thank you very much for your attention.